antibiotic injections, is that, and maybe we can start the panel discussion with this question. I'm asking to the panel, intravitreal, anterior chamber injection of antibiotic agents by the end of the surgery, is that a standard of care in all countries? Maybe starting with you, Jennifer?
Yeah, we do.
Yeah.
For all cases.
Okay, Mark?
We do certainly for cataract surgeries and where we leave something behind.
Okay.
Yeah, for us, I'll just take a minute. Over the years, the trends have changed in the sense previously we only used to use intracameral antibiotics for certain specific criteria, say for one-eyed patients or patients where you've had a complication on table, you've got a PC rent, or those with whom you have started with a poor ocular surface. But with time, yes, intracameral antibiotics have become, on par, on course. A small observation that we have observed in our setup is, unlike a lot of studies where giving intracameral antibiotics has brought down the incidence of endophthalmitis, in our setup, the incidence is the same. But in case a patient develops an endophthalmitis in spite of the prophylaxis, the overall course we have seen is milder and the patients recover better. So that would still be a case to inject intracamerals at the end of routine surgeries.
Okay.
Yeah, we do. We routinely do it after cataract surgery. We end intracameral cephalosporin. Yep.
Okay. Do we have any questions from the auditorium? Yes?
Yeah.
Please.
Please come to the microphone.
One question for you, Dr. Hattebach. What many of us believe that performing a good vitrectomy is very difficult in endophthalmitis cases because you have the timing factor there. So if you had to wait for certain time to do your full vitrectomy with silicone oil, wouldn't it be better just to inject the antibiotic, as Jan van Mers says? Because if you need to have the setup for the vitrectomy and all the things, several hours are going to go by.
So the question was to inject the antibiotic first?
The question is, if you can do the vitrectomy just an hour after you see the patient, we both agree. But if that cannot be done, and it happens quite often, what would be your approach?
Well, in many cases, we, or I would say in most cases, we still try to perform vitrectomy right away in those patients. But if it's not possible for several reasons, because some of the, or many of the patients with endogenous endophthalmitis are immunocompromised patients, and they have a high risk for surgery, we also prefer to inject antibiotic agents. And maybe after stabilization of the patient, then perform the vitrectomy. Yeah.
I would also make it dependent on visual acuity. So if someone's hand movement or below, I would rather go for a direct vitrectomy. If visual acuity is still good, you might try intravitreal antibiotics first.
If I may add, I think, your question is a good one, in part because, in many ORs, this was my case here in Amsterdam, having access was always difficult, and there could be sometimes a delay of 3 or 4 hours. So if there's a rapid decrease, you need to be able to treat. And we've talked about cultures. The other is, of course, we can get PCR now. And the PCR, I think, is very important. If you're going to inject antibiotics, it should be done. If you can't do vitrectomy within an hour, I would put in antibiotics. But I want a sample to know if I can at least confirm the diagnosis. So either get a biopsy at the same time, and you could do that in a procedure room, or otherwise you want to at least get a sample you can send off so you can get PCR. And as soon as you can do the vitrectomy, you do the vitrectomy and you re-inject antibiotics.
We have another question.
Yes, thank you. Jens Kilgaard from Copenhagen. I just have a comment on the endogenous endophthalmitis, because I think it might be different in India, but in Copenhagen, the endogenous endophthalmitis is either in an immune-compromised patient, it has a systemic focus, and it's often in the heart. And basically, I think to delay for a vitrectomy where the sampling often don't lead to a microbiological diagnosis could endanger the patient for having a systemic failure or shock. So basically, I think it is a failure not to mention that the systemic condition of the patient should be considered before doing an endophthalmitis.
Yeah,
Absolutely.
definitely. I would definitely totally agree with you because in many of these patients, they have so many other systemic problems that this is even more important than operating the eye. But fortunately, in many cases, we have, because it's completely different from acute endophthalmitis, which occurs postoperatively, and in many of these patients, endogenous endophthalmitis develops slowly, so we have time. And this makes it a little bit easier in order to stabilize the patient and perform additional systemic treatments. Yeah.
So my other comment is to the push of vitrectomy in postoperative endophthalmitis. So the EVS was a randomized study. All other studies have been case control or control case series, which is a lower level of evidence. And this is what we in Denmark call the resistance of surgeons to evidence-based medicine. So it is nice to do a vitrectomy, but it doesn't seem to be superior. And the conclusion of the slide was it maybe is superior to do a vitrectomy. This is solely a personal opinion. So I also like to do a vitrectomy, but it's not better to do a vitrectomy than it is to do antibiotics. And I think Mark Desmet's comment of delaying just to do a vitrectomy instead of putting in antibiotics is crucial in these cases. So it's just if you want to educate people, I think you should be very clear that the evidence is there's no difference unless you have hand movements or light perception. And vitrectomy might be a good idea to sampling or whatever you want to do, but it's not better.
The key is the antibiotics early, and even if you look carefully at the EVS study, about 40 to 50% of the patients in the non-vitrectomized group within a week had a vitrectomy. So the time, it's not so much yes or no, it's treat early and then do what's necessary for that eye.
Completely
So
agree.
I would just like to make another short comment. Though the EVS did not directly compare vitrectomy versus a TAP, if you look at the sub-analysis of the data, there is a comparison given between the vitreous TAP and a core limited vitrectomy. Now, a complete vitrectomy was not done in those days, but you can have some sort of an analogy where they have seen the number of repeat procedures that were required in these two groups. And it very clearly shows that the group which only underwent a TAP had a significantly higher number of repeat procedures to stabilize the patient as against the group that underwent a core vitrectomy.
So
if you take
I'm
that-
aware of all the good reasons why to do a vitrectomy, but the visual outcome was the endpoint of the EVS study. It was not whether it was a TAP or not. So we do a TAP every time we have an endophthalmitis, and still we, in 30% of cases, we don't get a diagnosis. So should we not treat? No, probably not. We should treat and then hope for a diagnosis. And I completely agree, a TAP is nice, but it's not, if it's a question of saving the eye for the patient, it's not a crucial point.
Yeah, however, I think we can agree that unfortunately the endophthalmitis study from 1995 is still the only one which compared what we want to know. And many things have changed since then. And you're right, there's no comparable study so far which could answer this question anew. And we still have a significant lack of the required data. But on the other hand, there's, with the advancement of vitreoretinal surgery over time, I still think, and this is not only the case in Germany, and obviously also in many other countries like India, most of us would agree that at the moment, when it comes to the patient, early vitrectomy is probably the best approach. Yeah.
Do we have one more question from the audience there? Then please, a very short question, short answer, because we're running out of time.
Oh dear. My question's with regard to endophthalmitis following intravitreal injections, typically anti-VEGF. So we've recently had 2 in diabetics, both of whom were really poorly controlled blood sugars. I wonder whether we should not perhaps be doing intravitreal injections on these where the HbA1c is really poor, because of the increased risk, or should we be giving them, post-op antibiotics? Would you suggest that? And the second question would be, if the the intravitreal antibiotic, if 48 hours post-treatment they are not showing improvement, would you then go to vitrectomy or a second injection?
Well, if you ask me personally, I would not go for a second injection. I would then definitely go for vitrectomy. I don't know. How about you, Vivek?
Same.
Yeah.
Yeah, my answer would be the same.
I would absolutely agree.
Yeah. I don't know how many cases you inject, but having 2 cases, one after the other, that happens. I mean, at one point I had 3 cases of strep endophthalmitis in the same endophthalmitis after cataract surgery in the same day in my service, and I thought, are we going to stop, or are we going to try to find the cause? You have to go through the whole procedure and see, are you masking yourself well? Is the disinfection done very carefully? Is there something else that could bring the infection inside the eye? What is the cause? Is it a strep, for example, which is probably from the surgeon himself? And they're hard to diagnose. They're in the posterior pole. I agree that a vitrectomy probably is the better way to go. Although if you know, again, the key is to be able to inject antibiotics into that eye to try and sterilize the situation. And luckily here, if it's responsive, your one injection should have sterilized the eye.
Yeah. So I think the take-home message for today, and unfortunately we will have to close the session timely, is that this is endophthalmitis, postoperative endophthalmitis at all, and the treatment is a very important issue. And so maybe we will have time to discuss about this next year. Wishing you a safe trip back home.
Thank you.
Thank you.